Thank you, respected chairpersons. At the outset, I'd like to thank Dr. Durusha Madam, Dr. Sujata Kar, Dr. Padmareka Jirge, Dr. Madhuri Patil, and the entire team at PCO Society for giving me this opportunity. A very good morning to everyone. So my talk for today is use of oral ovulogens in non-ART cycles. So in PCOS, anovulation is seen in nearly 70% of women, and hence use of oral ovulation inducing agents forms a very important armamentarium in the management of infertility in PCOS. So the outline of our discussion today is going to be on what are the agents that are available today, some of its practical application, which is the better drug, what is the evidence, how do we manage some challenging situations when we're doing ovulation induction, what is their adverse effect profile like, and when to stop. So the list is long. So we have the SERMs, that is clomiphene and tamoxifen, aromatase inhibitors, that is letrozole and anastrozole, various insulin sensitizers, as we've heard from morning, metformin, inositols, N-acetylcysteine, and the thiazolidinediones, and other drugs, adjuvants like glucocorticoids. So we'll talk about only the ones that are commonly used. So first SERM, that is clomiphene. So we all know the mechanism of action. So it acts as a central agonist. So it attaches itself to the nuclear estradiol receptors, and it stays on the receptor for a long time because of its long half-life, results in reduced negative feedback from estradiol at a hypothalamic level, and this causes increase in GnRH secretion and in turn increased endogenous FSH, and this stimulates ovulation. And because of its relatively long half-life, it exerts some action on the luteal phase as well. But some of the problems that we do see are the anti-estrogenic effect on the endometrium and cervical mucus and result in thin endometrium, and the propensity for multifollicular growth. So we always start with a starting dose of 50 milligram for 5 days. It can be started anywhere from day 2 to day 5 of cycle. It is very important to document ovulation at least in the first cycle. This is for two reasons. One is to determine what the ovulatory dose is, because there are many people who may not ovulate to 50 milligrams. And second, to reduce the risk of multiple pregnancies. Since multiple follicular growth is known, so if we know that a particular dose is producing more number of follicles, then we know that we need to reduce the dose subsequently. So if there is no ovulation with a small dose, we increase to 100 and then go up to 150. So it is now recommended that the maximum dose should not be more than 100 or 150 based on the FDA recommendation. So if a woman is obese, then addition of metformin would be more effective. Clomiphene, we see an ovulation rate of nearly about 85%, but unfortunately pregnancy rates are almost as low as 35 to 40%, and this is thought to be because of the anti-estrogenic action. Adverse effects, minor things like hot flushes, headaches, or visual disturbances. So if there's anything disturbing the patient, we discontinue and change the drug. The important complications such as ovarian hyperstimulation are seen in about 0.5%, multiple pregnancy about 4%, and at least 25% of them can be clomiphene resistant. So what are the challenges that we face when we are doing induction? Two problems. One, clomiphene failure, that is the woman is ovulating but doesn't get pregnant. Second, clomiphene resistance, that is there is no ovulation to maximum dose of 150. So what do we do? So if there is resistance, obviously it's because of increased insulin resistance. So we ask them to lose weight. We can try an extended course and give not 5 days but 7 to 10 days. We can combine the therapy with metformin, with gonadotropins, or controversially with glucocorticoids. So normally what we do is that we give a particular dose. If she doesn't respond, we allow her to get a withdrawal bleed, then increase the dose in the subsequent cycle. But some people have also recommended what is called the stair-step protocol, where in the same cycle, without inducing the withdrawal bleed, you can give subsequent doses you give the dose, do a scan after a week. If there's no response, give the higher dose in the same cycle. So you're able to give the entire 3 doses in a period of 6 weeks. So this way we reduce the time to ovulation and the time to pregnancy. So what we should remember is when there is clomiphene resistance, so the options are change the drug, try letrozole, or change to gonadotropin induction, or do ovarian drilling. If nothing works, then go for IVF. If there is clomiphene failure, the woman is already ovulating, so treat this as unexplained infertility, move to gonadotropin induction or go to IVF. Addition of glucocorticoids, some people prefer to do it when there is elevated DHEAs. Some people have also tried it where the DHEA levels are normal with clomiphene resistance. It's given in the follicular phase for about 10 to 14 days, and some people have found improved ovulation rates, but not to be used routinely. Next is the aromatase inhibitors. So these mainly act by inhibiting the aromatase enzyme. So there are two repercussions. So one is reduced conversion of testosterone to estradiol, and second is there is an increased accumulation of intraovarian androgens, which in turn is supposed to make the follicles more responsive to FSH. So the differences between clomiphene and letrozole is that letrozole is not associated with anti-estrogenic effects on the endometrium. It has a shorter half-life compared to clomiphene. The clomiphene is around 2 weeks, where this is just 45 hours. There is a greater chance of monoovulation here because the feedback mechanisms are intact. So once there is emergence of a dominant follicle, the remaining follicles don't get recruited, and hence there is a lower risk of multiple pregnancy. So here the dose is started with 2.5 milligrams. You can increase to 5 and go up to 7.5. Side effect profile is better compared to clomiphene. So what are the challenges? So even with letrozole, though the ovulation rates are better, there is still a possibility of no response. So what do we do in these cases? So you can increase the dose up to 7.5. You can give an extended protocol. So instead of 5 days, give it for 7 to 10 days. You can use a similar stress step protocol like what we did with the clomiphene. You can also give a step-up protocol, such as you can give 2.5, 5, 7.5, and 10 from day 2, day 3 onwards for 4 days. You can also combine the therapy with metformin or with gonadotropins. So what about the comparison? Which drug is more efficacious? So the evidence is quite clear. So there have been a number of RCTs performed over the years. So if we look at this one of these landmark Dr. Lee Gross paper, so we can see that the ovulation rates are almost 88% with letrozole, significantly higher when compared to clomiphene. So in the latest meta-analysis, we can see that very clearly the probability of ovulation is significantly higher with letrozole. And so also goes on to clinical pregnancy and live birth rates. So in this IPD meta-analysis published a couple of years ago, we see very clearly that both the clinical pregnancy rates as well as live birth rates are significantly higher with letrozole compared to clomiphene, and the time to pregnancy also is lesser with letrozole. And this is the foundation for the recommendation with the PCOS guidelines saying that letrozole should be the first line of ovulation induction in PCOS. What about OHSS multiple pregnancy miscarriage rates? So from the Cochrane published in 2018, there is very good quality evidence that OHSS rates are almost similar in both drugs, about 0.5%. They did not find any difference in the rate of miscarriage between the two groups. And in the Cochrane, we do see that the multiple pregnancy rates are similar, but then we do know that the multifollicular growth is more with clomiphene, so multiple pregnancy rate may be slightly higher with clomiphene. So what about endometrium? Again, there is no debate that endometrial thickness is lower in clomiphene compared to letrozole. So it is lowest with clomiphene, intermediate with letrozole, and highest with gonadotropin induction. And people have also looked at various ultrasonic parameters to evaluate receptivity and found that with almost all the indices, letrozole fared better. So to conclude, based on all these observations, now it is very clear today that letrozole should be the first line of ovulation induction. So this is from the latest PCOS recommendations. So also the failure to ovulate, that is letrozole resistance, is lower with letrozole compared to clomiphene, and we have to remember about multiple pregnancy. So once we have a follicle, should we trigger with HCG or should we just allow them to have natural intercourse? So we need to trigger only if we want to time the ovulation and if we want to time intercourse, but with trigger comes problems. One is we can give a trigger too prematurely when the oocyte is probably still immature, cost factor, and it introduces a concept of having intercourse on demand, which can result in performance anxiety. So according to Cochrane, there is limited data to show that whether you give HCG or not, the pregnancy rates are almost the same. So you can just probably just do whatever suits the clinician and the couple. So what about insulin sensitizers? I think a lot has been discussed from morning, so I will just not go into too much of detail except for the fertility bit. So there is good evidence today to say that metformin is better than placebo. If you don't give anything versus giving metformin, there is definitely improvement in ovulation rate, pregnancy rate and live birth rate. So it's because of this that metformin can be used as a first line drug for ovulation induction in PCOS according to the PCOS guidelines. But we have to remember that there are better options. Definitely clomiphene and letrozole work better than metformin alone. And if a woman is obese, then addition or a combination of clomiphene and metformin works better. The inositols, so it is a promising drug. There is some emerging evidence to suggest that there is some metabolic, hormonal and ovulatory benefit, but still the evidence about its actual impact on live birth rate is not very robust. So though it is freely available, it's not really very inexpensive. It is quite expensive in India. Side effect profile is better than metformin, but still in view of the limited evidence, the data the recommendation still says that it should still be considered an experimental therapy and we should wait for further evidence. Maybe one of the indications to give this would be if someone is intolerant to metformin. N-acetyl cysteine, again slightly better than placebo for ovulation and live birth, but definitely metformin did better than N-acetyl cysteine. So what about letrozole and congenital malformations? So a lot of ups and downs in terms of its reputation and a lot of bans and revoking bans we have seen over the years. So for a drug to be teratogenic, it has to be present at the time of organogenesis. So we all know letrozole has a half-life of 45 hours. It is eliminated after 5 half-lives, that is 10 days after the last dose, that is by day 17. So likelihood of letrozole being present at the time of implantation is quite negligible. So that kind of refutes the theory that it may have some impact. So there is a very good systematic review published in HRU in 2021, which includes about 46 RCTs and cohort studies. They found that the overall malformation rate with letrozole was 2.2%. and major malformations was 1.6% with letrozole and 2.5% with clomiphene. So clomiphene is slightly higher, though not significant. And there was no increased risk of miscarriage as well. So I think that's quite clear that letrozole is quite safe. So what about cancer risk? So this is also another excellent meta-analysis published just last year where they looked at cancer incidence in fertility treatment versus no treatment. So they found that borderline ovarian tumors, there was a significant association. And when they did a subgroup analysis, they found that ovarian cancer incidence was higher in the group which underwent IVF as well as the group that underwent clomiphene citrate treatment. So I think this should be a word of caution, and this should be the basis why indiscriminate and prolonged use of ovulation induction should not be done. We should limit our ovulation induction to perhaps not more than 6 months for two reasons. One is unnecessary and prolonged use can probably result in cancer risk later on in life. And more importantly, what has been seen is that 75% of the pregnancies do occur in the first 3 or 4 cycles and very few occurred after 6 cycles. And this is the basis for the recommendation with the NICE guidelines, which says that do not continue treatment for more than 6 months. If there are 6 failed cycles, it is better to treat this as an unexplained infertility and move on with treatment. So yeah, so that's about it. So I think I just wanted to conclude with this slide. So though we see, it seems that ovulation induction is a very simple form of treatment. It's one of the most remarkable achievements in the field of medicine. And this is just to pay tribute to the founders. So this is Dr. Frank Palopoli, who synthesized the clomiphene molecule. And this is Dr. Robert Greenblatt, who was the clinician who was involved in the first few clinical studies. And he was responsible for the first few pregnancies, which resulted in this landmark publication in 1961. A big salute to them, and I think this has formed the foundation for fertility treatment as we know it today. Thank you.